Hey there, and welcome. My name is Pedro Barata. I'm a GU oncologist out of University Hospital Seidman Cancer Center in Cleveland, Ohio. I'm very happy to join the GMAD platform and discuss in the next few minutes this interesting case that was posted here. 64-year-old man known with metastatic CRPC, and the idea here was to consider treatment options and have a discussion around that. Just as a way of background, this was a patient diagnosed with a Gleason 8, 4+4, underwent radical prostatectomy several years ago, ended up recurring. At that time, he received ADT. He was on ADT for a number of years, let's say 3 years or so, and then started developing CRPC with a doubling time of around 5 months. So confirmed rising PSA. This was before novel imaging was available, PET scan was available, so you end up getting conventional scans, bone scan, CT scan, which revealed basically osseous metastasis, disseminated bone disease. So this is a patient who developed metastatic castration-resistant prostate cancer, who progressed while on ADT for 3 years for recurrent prostate cancer. Interestingly enough, the team offered him germline testing, and he has a BRCA1 germline mutation. And I think that triggered a lot of the conversation around what to do. So when we look at the options considered for us to talk about, there was a number of options here which are supported based on the data that's been developed for these patients, right? So there was a conversation around whether or not the RPI alone would be appropriate with enzalutamide or abiraterone. I would go immediately in my mind to data from PREVAIL and Cook 302. Then you have the 3 trials supporting the different combinations of a PARP inhibitor with an RPI, PROPEL for abiraterone olaparib, Magnitude for abiraterone niraparib, and finally TALAPRO-2 for enzalutamide talazoparib. And finally, more recently presented data with a different combination, enzalutamide with radium-223 based on the European study PEACE-3. When we go over the sense from the team, the group that replied to this question around what would be the preferred treatment at this time, most folks voted for enza radium-223, followed by enza talazoparib, and the least options here considered were magnitude approach, abi-nira, or abi or enza monotherapy. So I'm going to go through them, but just trying to quickly touch on the aspects about that pertain to this case that maybe can help us kind of make a thought process around how to do it. So one is, of course, the presence of BRCA1 germline mutation, and we know that BRCA has a prognostic role, as a predictive role, right? It's prognostic. These patients tend to do worse than the general population. So we know that conventional treatments are not as effective as they are for the general population. And so we need better. And often these tumors are more aggressive. They might be or not associated with other molecular characteristics of aggressiveness like TP53 or RB1 or PTEN and others. So these would be, so when I see a BRCA1 patient, I have that in mind to consider that. When I look at combination strategies compared to ARPI monotherapy, I don't go with an RPI monotherapy for most of my patients with mCRPC. So probably of all these options, my least favorite approach would have been an RPI monotherapy for that reason. Then you have aspects related to tolerability of these different options. You can think of efficacy, and I'll remind you that the combinations of enzalutamide talazoparib or olaparib abiraterone or enzalutamide radium-223, the overall survival, the median overall survival achieved in the patients treated in this trial with the combination has been over 40 months. So it's been the highest absolute numbers we've seen, although we don't do head-to-head comparisons. But in absolute numbers, we're starting to see overall survival getting, over 3 years, closer to 4 years. So that's an improvement, because up to that point, with the RPIs, we are expecting median overall survival from 2 to 3 years, depending on the study data or the real-world data sets that we consider. So the efficacy does work. We're able to control the disease. One aspect is all the combinations with PARPs. The availability of these combinations exists for BRCA1 in the context of olaparib, abi, or niraparib, abi, because they're BRCA, is a broader label for the talazoparib enzalutamide. So I would argue all the PARP combinations are available, would have been available to this patient, as well as radium enzalutamide. Another aspect here has to do with prior therapy. This is a patient progressing to CRPC not previously exposed to an ARPI, which I would say is probably how all these trials were designed to look into it. So I think data from PIS-3 as well as data from TLAPR-2, PROPEL, and Magnitude kind of mimic this patient population, if you will. And so from that perspective, I think these are very reasonable options. As far as toxicity goes, I think it's important to keep in mind the cytopenias, the hematologic toxicity that we see with the PARP inhibition, right? As well, we do see that in a bit lesser extent with radium-223. That brings me to the point around how do we handle these patients, and the reminder of the bone modifying agents. Whether you're going to do zoledronic acid or denosumab, it's important to keep in mind for a patient like this who has bone metastasis and CRPC. Then the next question is, should we consider a treatment like radium-223 where there's data suggesting a synergy or enhanced activity for patients who harbor HR like a BRCA1 versus a PARP inhibitor for the same patient? So we don't have a head-to-head study answering the question. If I were to think the same RPI enzalutamide, should I go with radium-223 combined with enzalutamide, or should I go with talazoparib combined with enzalutamide instead? We don't have that data, right? And another perspective that I want to bring up is the overall survival endpoint. So we've seen the overall survival for the HR positive population on TLAPR-2 as well as the unselected population. And also we see a signal for the ENZA radium PIS-3 trial, although the overall survival is not final, but we do see a signal. So I would not be surprised if we see survival advantage there as well. Then, of course, when we're asking about what to do with these patients, we also need to think about what about radioligand therapies. We just got a recent approval for lutetium PSMA in the setting of pre-chemotherapy mCRPC. Now the caveat here is, I would argue, this has been a patient, our patient is a patient has not been exposed to an RPI, which is different from the data that we've seen that led to the approval of lutetium PSMA, which is a post-RPI population in the PSMA4 patients. And the press release, for some who are thinking about the press release around PSMA addition with lutetium PSMA, it goes in combination with the RPI and ADT for metastatic hormone sensitive. So if you want to stay on label, I would say that the trials that really test the activity of therapies in the mCRPC post-ADT, I would also summarize the PIS-3, TLAPR-2, PROPEL, Magnitude, if you will. And as I said, it would not be my preferred option to go with COOK-302 or PREVAIL for ENZA and ABI monotherapy. So finally, so I would say with a BRCA1 patient, I would be debating, to be honest, between a combination of radium ENZA or probably PARP ARPI. I tend to do talazoparib ENZA or olaparib abiraterone, if you will, and that's probably what I'll be debating. There's data that the activity of the PARP inhibition might not be exactly the same when you look at BRCA1s versus BRCA2. Seems like the signal is mainly driven by BRCA2. So if I go with a PARP in these patients, especially for patients that are not being exposed to RPI, I definitely prefer a combination versus an RPI sequenced by a PARP inhibitor. So so from that perspective, I would be debating, from that standpoint. Knowing what I know, I probably would go with a PARP RPI in this context if the patient would understand the hematologic toxicity, the small risk but real nonetheless for thromboembolic events, the risk for maybe second malignancies, which is small, very few cases reported, but nonetheless not zero, as well as anemia, need for transfusions, etc. And that usually happens within the first few months managing toxicity. If toxicity is a concern, I would argue probably we're more used to do radium-223 because it's been around for a long time. I'm very comfortable with that, and enzalutamide. And so from that perspective, it's very easy to do. I would just add, of course, definitely keep in mind the bone modifying agent for this patient as you offer this combination. So to me, I probably would go with the group that voted mainly enza-telazo or enza-radium-223, but with the aspects that I considered here. It's important to have a conversation with the patient around the prognostic value of the BRCA1 alteration. It's important to consider if you go with enza-radium, this probably is going to be a patient that will see a PARP inhibitor, if you will. If you do enza-radium up front, you probably would offer a PARP monotherapy afterwards because it's a patient progressing on ARPI enzalutamide. And then the question then becomes, what are you going to do upon progression? Are you going to do chemotherapy? Are you going to do a radioligand therapy or a different option? And again, we don't have head-to-head studies. If you want to use data to think of it, you could think of a Triton 3 data comparing rucaparib against second agent ARPI or docetaxel. Is a positive study for PFS favoring rucaparib. So maybe you could borrow that data to make the claim that if it was me, I probably would go with the PARP before going with chemo. That conversation for a BRCA1 patient, but that conversation could be different depending on the HR alteration that you have, that you consider. For example, it's different if you have an ATM or a BRCA2 or a PALB2 or RAD51, etc., FANCA, etc. So I would invite you all to read the analysis put together by the FDA on JCO that actually looks at the activity of the PARP inhibitors by itself as well as combo gene by gene. So that's actually a very good paper that I tend to use quite a bit. As far as enza-radium, it's very, very important data, European study. So we might see a change in label in the near future. Radium has been shown to be a very safe partner to combine with. We've seen data with PARP. We've seen data with RPIs, of course. There's other data being tested out with radioligand therapy, etc. So, the experience in the community with radium has been very favorable. So the message here, final message is genetic testing is relevant. We should think for metastatic patients to do germline and somatic testing. That drives our conversations with patients. Important to keep in mind the prognostic implications, the predictive implications, and the implications for the family. So this would have been a patient I would have referred to genetic counseling. And as you think of active treatment for prostate cancer, please keep in mind symptomatic therapy, supportive care therapy, including bone modifying agents. So with that, I hope you find this video useful for you. Thank you for your feedback. A lot of great thoughts in the comments here for this case, and I hope to see you soon. Thank you so much.